Today.
Very well. I'm very well, and thank you. We're glad you're with us, and I'm going to go ahead and start the recording, and we will welcome you all and look forward to our discussion. Please feel free to raise your hand or ask a question verbally, or to type it into the chat as we go along. And I will pause to take a look at that regularly. We're going to continue our discussion about hepatic tumors. Last month, we talked about hepatocellular carcinoma in great detail. And so I'll begin today by talking about hepatoblastoma. Quite a different situation, because this is usually young children. It's extremely rare in adolescents and in adults. In fact, this is the most common liver tumor in the pediatric age group. So if you see a liver tumor and you guess hepatoblastoma and the patient's under 5 or 6 years old, you're going to be right about 80 or 90% of the time. But like blastomas in other sites, these can have a mixture of components. And unfortunately, I only have 4 examples to share with you, and these are all quite similar. But there are a variety of other patterns with mixed epithelial mesenchymal components, various small cell or macrotrabecular features, and so forth. So I apologize that I can't give you a full rendition. However, I will post in the link with this a wonderful talk by my colleague, Dr. Jongsin Yu, who is a pediatric pathologist and who spoke on one of our sessions and spent quite a bit of time on hepatoblastoma. So if I can be forgiven for not being a pediatric expert, at least I can refer you to one who is. Now, most of the time, the clinical and other features such as elevated AFP, young child, liver mass, isolated tumor, no other signs, are sufficient to generate the diagnosis. But sometimes a needle biopsy is performed. I'm going to just expand here. Let's see. And it may be an FNA biopsy, or it may be, as in this case, a needle core biopsy, very narrow gauge. And as you can see, here we have a somewhat trabecular or nested pattern with some sinusoidal-like structures, but very immature cells with a lot of uniformity to the nuclei, high NC ratio. And as you can see here, there's also a lot of the sectioning artifact, or this sort of chatter. And that usually indicates that the tissue is somewhat brittle. It has an altered component of nuclear DNA, cytoplasmic structures, and so forth. And so the tissue fractures very easily, as you see here. Maybe a little bit more normal hepatic tissue here, but hard to tell. We'll look at a little bit more, a few other of these small fragments here. Here's another piece where you can see a lot of this chattering artifact from the section. Now, we see this in a number of other tumors, and in the colon, for example, this is oftentimes a great indicator that that you're dealing with a polyp or a dysplastic lesion. And as you can see, it makes the morphology difficult. So good fixation, careful histology can be very helpful, but sometimes even the artifacts like this contribute to recognizing the disorder. So the slide that we're going to go to next is a resection. And here we can see normal liver down here at the bottom. And then we see a very blue area up here, somewhat pinker transitional area over here, some areas of hemosiderin, hemorrhage, and variable fibrosis here. So probably this tumor has been partially treated because you've got some areas of hemorrhage, fibrosis, and hemosiderin deposition in this area. Now, as we look at the tumor here in the area that's nicely fixed, you can again see this very fetal appearing blastomatous type tissue with very high NC ratio, sort of amphiphilic cytoplasm, and a trabecular or sort of wandering pattern. Here's a more solid area of this very immature type of liver tissue. The hepatoblastoma is trying to recapitulate the stages of growth. And so sometimes you'll see a small tubular formation like you do here. And other times it will be just more solid sheets with a little bit of trabecularization and maybe some admixed stroma to indicate that there's development of a lobule type of structure. Now, usually immunohistochemistry is not required in this setting, but if we need to do it, there are characteristic findings. Of course, the tumors are usually very strongly positive for AFP. That would be a helpful marker. They'll also stain with some liver markers like hePAR or glutamine synthetase and so forth. They may also have CEA and various cytokeratins, such as cytokeratin 7 and cytokeratin 19. Here's another example. You can see again this fairly similar cytology, a bit of eosinophilic cytoplasm, large nuclei, and not defined structures in the sense of glands or other sorts of things usually. A little bit of sort of pseudo-rosetting may be seen, like you see here, this semi-glandular formation. And the margins are usually fairly sharp. These tend to be right-sided lesions a little bit more than left-sided. And so that makes the surgery sometimes a little bit more challenging. Here's another example, very blue example. You can see a sharp margin here. And this is sort of an almost angiomatous type of pattern with a very immature blastomatous type of tissue, very immature scant cytoplasm, a lot of open vacuolar type spaces or pseudo glandular spaces, and interstitial hemorrhage and so forth that you can see here. Sort of a pseudo angiomatous pattern. So fairly uniform all throughout pattern. And then the last case I'll show you, again, I think this is one that's been partly treated, but maybe a little bit different pattern. Here you can see there's more of a mesenchymal component. Oh, I think this may be the wrong slide. Yeah, I think this is the wrong slide. This is a chondroblastoma rather than a hepatoblastoma. Although you can see a little bit of the same sort of blastomatous nature to the cells, but this is an out of place slide. And I picked that up based on the calcification pattern, which you see here. which is very characteristic of chondroblastomas, this sort of membranous pattern called chicken wire pattern of calcifications. So my apologies for that, but it makes for a little bit of humor. All right, here's the next hepatoblastoma. And I think this is our last case. You can see here maybe a little bit more cytoplasm. We have a lot of hemosiderin here as well, perhaps because of this hemorrhage or possible prior treatment. A little bit more differentiation to this tumor. The cells get a little bit bigger, more cytoplasm. Still no good development of great sinusoids, but sort of starting to look like you might be starting to get some sinusoids in a couple of these areas like this. So a little bit of development differentiation in this area, hardly any here. You can see some mitoses. So any questions about hepatoblastoma before we leave this? Okay, well, let's go on then to the bile duct tumors. And we're going to talk first about a sort of a mixed entity that is kind of hard to define, which is, but it's recognized that there are a number of tumors that overlap between hepatocellular carcinoma and cholangiocarcinoma. And so recognizing that there are these combined tumors, this is a brief nod to that. This is usually something that we make the diagnosis based on H&E morphology. Immunohistochemistry can help us, but primarily this is a tumor that has sort of a dual component or dual differentiation, sometimes in different areas and sometimes a little bit more mixed up with each other. So you'll see in these examples what I mean by that. So here's a resection of liver. You see a blue nodule invasive tumor here. And then we see something a little different up here. So let's take a look at this pink area first. And this looks like bile duct type of tissue, doesn't it? Very angulated glands, very hyalinized fibrotic stroma, very collagen rich, and variable size to these glands, some angulated, some small and round, a little bit of redundancy, relatively low grade cytology. We don't see dramatic anaplasia. We don't see tumoral necrosis. So if we just had this pattern, we might say, well, that looks like cholangiocarcinoma. But we also have this part down here, much more cellular and more sheet-like pattern of growth, a little bit of pseudoglandular formation, a little bit more hepatoid appearance to these cells, maybe a little bit similar to that hepatoblastoma morphology that we just looked at. Here there are some glandular structures or rounded spaces like this. And so this pattern you could call a combined hepatocellular cholangiocarcinoma, particularly if you had any sort of hepatoid markers being expressed in this area, like glypican-3 or arginase or hepar-1, or the absence of CK7, for example, or even just a different pattern of CK7 between this tumor and this tumor, I think would enable you to call this a combined hepatocellular and cholangiocarcinoma. Here's another example. In this one, we don't seem to have the distinct separate areas. But I think as we look at this, you'll see there's a little bit of dual morphology to some of these areas. So looking at this, it looks like there's kind of two populations of cells here. You have a number of cells with kind of clear cytoplasm, and then you have some other cells where there's more eosinophilic cytoplasm. And so that's another clue that you may be dealing with a sort of combined tumor, is if you see this sort of intercellular variation with kind of a dual morphology that's kind of all mixed up. This is sort of like they took the hepatocellular component and the cholangio component, and they mixed them all up in one bag and then poured it out so that it's forming a single mass. But even in doing so, it's like you've got red marbles and white marbles, so there's a little bit of a difference here. And again, here, immunohistochemistry would probably be the most useful thing in a situation like this to see if you were actually getting differential expression. Now, we'll also look at this area up here, which looks, again, a little bit different, more hepatoid, as you see here. Solid nests, rounded. So this component looks more clearly to be hepatocellular. It doesn't have that dual nature. You also have the tumor infiltrating lymphocytes here to a much greater degree. And if you just had a high power view of this, you might say, well, that looks like hepatocellular carcinoma. So those are the morphologies in this one. It's slightly different between this area up here with the lymphoid component and our area down here with the more fibrotic appearance. Now, many of the same risk factors for hepatocellular carcinoma apply to this combined neoplasm as well. So alcohol, hepatitis, and so forth. Here's an area here where it's much more characteristically cholangiocarcinoma, because you've got this very hyaline fibrosis here in this area, as you can see. So this would be a good case to come back and study on your own, just to get familiar with those morphologies. Here's another one similar to our first case, where we have a solid blue component here, nested, fairly eosinophilic cytoplasm, sheet-like pattern of growth. That's not the usual pattern for cholangiocarcinoma, but looking right next door here, again, we have this very hyalinized pattern of growth, angulated glands with the cytology of cholangiocarcinoma. So that dual morphology can be helpful if it's present, particularly. And then one more case. This is not a combined case, but I want to show you to illustrate a point here. So we have this nodule up here of tumor cells. This looks like hepatocellular carcinoma. You've got cholestasis, intracytoplasmic bile. You've got a fairly low-grade pattern. No no bile ductular structure, no cholangio structures in here. Now, this tumor was treated by an interventional radiologist, so you see the embolization beads and polyvinyl alcohol here. And I want to show you what is not cholangiocarcinoma. So adjacent to this tumor is a very pronounced proliferation of bile duct type structures. You see there's this broad zone from here clear over to here with just bile ductular proliferation. But this is not carcinoma. This is the kind of bile duct proliferation that we get with cirrhosis and end stage changes due to cirrhosis. You'll see that there's a degree of nodularity to this. There's still some remaining architecture. And so those are features that say, I'm a reactive phenomenon rather than a neoplastic phenomenon. And so you want to be careful that you don't mistake this proliferation for a combined hepatocellular and cholangiocarcinoma. So seeing residual large ducts as well as intervening, structures here, this is indication that you had a normal hepatic lobular structure here that has regressed, and it's been supplanted by a bile ductular proliferation as these bile ducts looked further and further to find hepatocytes that could feed them bile, but they didn't find them. So they're just left proliferating in this nodular fashion. Okay, so that's combined hepatocellular cholangiocarcinoma. We'll go on now to cholangiocarcinoma, which of course is derived from the intrahepatic biliary tree when we're speaking in the liver. Of course, there are cholangiocarcinomas that occur in the extrahepatic ducts. We're not focusing on those this evening. One of the challenges, though, with cholangiocarcinoma is that it can look very similar to metastatic carcinoma. And so differentiation can be very challenging, especially if you just show up with multiple nodules in the liver, because sometimes cholangiocarcinoma sort of spreads along the biliary tree and can appear to be multifocal. There's one stain or one method that has been touted as being helpful. It's not very widely available yet, but it utilizes in situ hybridization for albumin RNA. And that is a feature of the intrahepatic bile ductular epithelium, is that they are able to develop or secrete the albumin, make albumin, and so they have this albumin RNA, which, if you can demonstrate that, it's a very good marker for intrahepatic rather than a metastatic tumor. Now, over in Asia, we know that there are a number of areas where liver flukes are still a problem, and those can develop a chronic inflammatory condition within the bile ducts that then leads to further mutations that can lead to cholangiocarcinoma. So TP53 and SMAD4 are typically associated with liver fluke infestation, whereas non-liver fluke related cases have either IDH1 or 2 or BAP1 mutation as kind of the instigating final pathway. So let's start with a needle biopsy. Here we see several cores, and these are fairly cellular, so they're not highly fibrotic. But you can see how, looking at a tumor like this, you might wonder about, breast cancer, or maybe pancreatic cancer, or you might wonder about even lung cancer, possibly. Sometimes can give a picture similar to this. Some small nested glands, a little bit of mucin, occasional more solid areas, as you see here. Now, these would, of course, be CK7 positive, but that can obviously come from a lot of different locations. Well, here's a wedge biopsy, which has more of that more typical hyaline fibrotic appearance. And you can see here, even though we have a few larger ductal spaces like these, this is not the same as that bile ductular proliferation that we saw in the cirrhotic liver with the hepatoma. So a little bit of mucin, angulated, and generally small glands is kind of the norm. They're not the big mega glands that you get often with colorectal cancers or something like that. And this is why we think oftentimes of possibly metastatic breast cancer, is because of this, small amount of mucin, small glandular pattern. Here's another example. This is not quite as well fixed, so I'll try to find a good area here. Again, we see the hyaline fibrosis, and here the glandular structures are staining a little bit differently. Small nests, hyaline fibrosis again, and some intervening necrosis as well. So we don't have any normal liver tissue on here for comparison. Well, maybe this is a normal duct up here. So yeah, this is probably a normal bile duct here. And in comparison, here's our neoplastic glands here. Higher grade nuclei, a little higher grade carcinoma, more spindly shaped a little bit as well. Here's another example. Now, in this case, the nests are sort of rounded. They have some sort of reddish pink luminal content. And look a little bit different. But this is part of the spectrum. That's one of the challenges as pathologists and as we try to train people, is to recognize both the classic features as well as some of the variations that we can see in these lesions, which is a great reason to be able to use digital slides, because you're not just locked into one or two photographic fields. Now, you might wonder here about combined hepatocellular cholangiocarcinoma, because here we see some more solid type growth with maybe some patterns of cytoplasmic membranes and nesting and little pseudoglandular formations. And so a case like this, you might find it worthwhile to do stains to rule out the combined versions or combined variant of this. In terms of prognosis, I'm not sure that the combined version is any less or more aggressive than the individual constituents. I think in general, cholangiocarcinoma is a little bit more difficult to treat surgically, and hepatocellular carcinoma is usually occurring in a setting of cirrhosis, whereas here we're not really seeing any sort of cirrhotic pattern in the background liver. We've got a little bit of fat, but generally it looks to be fairly unremarkable appearing liver. Normal portal structures here. Central vein is open. So no evidence of cirrhosis in this particular patient. So in that absence, certainly you'd be inclined to think more likely to be cholangiocarcinoma than combined, which usually will have some of that backdrop. So a different pattern and expression of these tumor cells here. Now here's another example, and here we do see what looks like a bit of cirrhosis in the backdrop. Rounded nests and some intervening inflammatory component in the portal tracts. Looks like I'm getting the colored circle of, there we go, finally got it loaded. So we do have a cirrhotic background, but looking at this tumor, this does not look like hepatocellular carcinoma. This is small rounded glands, small glands, single cells. This looks like a cholangiocarcinoma or possibly a metastatic carcinoma from another site. You'll have to take my word for it that this was evaluated and found to be cholangiocarcinoma. And so hopefully you'll believe that and can see some of the pattern. Again, a lot of inflammatory cells here and tumor infiltrating lymphocytes, which brings up the point about possible immunotherapies for some of these tumors. We know that patients with Lynch syndrome do have an increased risk of pancreaticobiliary tumors as well. And so while we're not confident that these tumor infiltrating lymphocytes are associated with mismatch repair defects or whatever, they might make it worth considering that possibility and potentially doing evaluation for mismatch repair defects to see if the patient might therefore qualify for immunotherapy, which can be quite dramatic in terms of responsiveness in those tumors where it's the dominant molecular pathway that's being upset. So here's normal hepatocytes here, and you see these tumor cells kind of destroying the lobule as they infiltrate or pervade through it. So we've mentioned immunohistochemistry can be useful in these circumstances. And I haven't given you exactly what the staining components are here, but I think perhaps you'll be able to surmise by the fact here as we look at the cirrhotic liver that these are all staining strikingly positive. These are the bile ducts. So this is pretty good evidence that we're dealing with a cytokeratin, and it's probably cytokeratin 7. As we look here at this tumor, we can see that the cells are all nice and strongly positive, as we would expect with a biliary cholangiocarcinoma type of lesion. So that's CK7. We take the next stain. Well, here's a negative stain, is nicely marked here. But we can see that it's positive in the hepatocytes. So this is a stain that is marking hepatocytes, probably HepAR1 or maybe arginase. It's very granular, so it's probably HepAR. And it's clearly negative over here in our area of tumor up here. So nice contrast there. And when we do immunohistochemistry, it's nice to have both positive and negative stains to confirm our impression so that we don't end up having to rely solely on a negative stain, for example, that might be falsely negative, either for staining reasons or antibody reasons or something like that. So here's a different stain. Let's take a look here at the piece of control tissue. The control tissue looks like it's a carcinoma, and we have a little bit of brush border and some cytoplasmic staining. It's not very diffuse. There's a few areas where it's maybe more cytoplasmic here. So that's our control. So it's something that stains in adenocarcinomas. So as we look here at the subject target tissue, let's look here at the liver tissue areas. And does anyone recognize this pattern? So we've got some staining here in and around these hepatocytes. So this is what's called a canalicular pattern. And that gives us a great notion that this is probably a CEA stain, which will stain the normal bile canaliculi in the liver. And so again, it can be a marker for hepatocytic differentiation, but as I indicated before, the small ductular proliferation in cholangio proliferation is also looking for those little canaliculi. And so here we're also seeing some degree of positive staining, not in quite the same pattern, but a little bit. I don't think this is just non-specific staining. It's not staining every cell, but it's staining some of the cells. So we wander through this a little bit. Here's an area like that. Here's an area here, where it's trying to find these little canalicular structures or develop them so that it can latch on to the biliary secretion. So just little small areas in a few of the tumor cells. This is not artifactual staining. This is actually what would be expected in this pattern. So this is, again, helpful in defining this as a cholangiocarcinoma in this case. Okay, well, if you've watched some of my videos, you probably recognize this case as well. This is the only case I have ever seen of this particular entity. And this is also a cholangiocarcinoma, but it is a very distinct morphologic type. So as you can see, we have a large glandular spaces filled with sort of a clear, pale fluid. We have fairly low to intermediate grade cytology, some gland-like formation, and some more solid areas in between. So this doesn't look a whole lot like the other cholangiocarcinomas that we have seen. And that's exactly why it's such a challenge, because you look at this and you might go, well, could this be, thyroid cancer? It's got some scalloping like thyroid colloid here. Could this be, something of that sort? Or could it be another tumor that makes these sort of follicle-like glandular structures? And I think it was probably that feature that led people to stain this particular tumor, which is CK7 positive, but it also has the distinctive feature of being positive for inhibin. Inhibin is usually used, in the ovary for sex cord stromal tumors like granulosa cell tumor. It may be positive in the adrenal. And so it's not usually an epithelial type marker that is positive, but it is expressed quite strongly in this particular variant of cholangiocarcinoma. And that is what defines this as the cholangioblastic type of cholangiocarcinoma. Now, we call it cholangioblastic because it is more immature looking. Aside from making these follicle or glandular-like spaces, these are more primitive cells than the small cholangiolar epithelium, which we might see out here on the periphery. Let's find it for comparison. Okay, so here's some for comparison where, you know, more pale cytoplasm orientation and so forth. So just a nice heads up to see this pattern and to occasionally try a wild stab at an inhibin stain if you think you might be dealing with this sort of a lesion. I think if we saw this on a core biopsy, which I think we did have a core biopsy of this case, we were completely stymied and really wondering about what it might be. So you've seen a rare tumor. Well, of course, in the liver, we also get neuroendocrine tumors. And I'm not going to spend time talking about those because they're very similar to what you see in neuroendocrine tumors elsewhere. I will mention, though, that primary neuroendocrine tumor in the liver is very uncommon. So if you see a neuroendocrine tumor in the liver, most likely it's metastatic from the pancreas, from the large bowel, but it is possible that it could be a primary tumor. But I'd want to make sure that they've been thoroughly examined and so forth with radiologic studies to make sure they didn't have a tumor somewhere else. Neuroendocrine carcinomas, again, would be very uncommon in the liver. These would have usually normal serum AFP with an elevated chromogranin or other neuroendocrine marker, and they might have evidence of vasoactive peptides with diarrhea and so forth. Mixed neuroendocrine, non-neuroendocrine tumors can also occur in the liver. I've never seen a case that's primary in the liver, so I don't have one to show you, but you can be aware that they can happen. And now we'll talk a little bit about some of the mesenchymal or stromal neoplasms that we can see in the liver. And this will be kind of our last section. There's a whole bunch of these. They're all the sorts of things that you can see elsewhere as well, possibly with the exception of undifferentiated embryonal sarcoma, which I don't have an example of. But angiosarcoma, hemangioendothelioma, these are lesions that can be seen elsewhere as well. So here's a nice little example of the benign lesion, hemangioma. So hemangiomas in the liver are very common. The radiologists usually are quite adept at finding them, although occasionally, for various reasons, they might end up being resected, either because of an intraoperative finding or because they didn't quite flow correctly on radiologic exam. So just be aware, you can have benign hemangiomas. Now, here's another lesion. And I think I have several slides from this same lesion. This is a challenging tumor. And as you can see here, we have some degree of preservation of the portal tracts. Here's a nice portal tract here with some bile ducts. Here's some more over here. So we have this sort of lobular pattern of growth that seems to be supplanting or replacing the hepatic lobules. And it's replacing them with a mixture of sort of fibromyxoid stroma. And these cells, which we see here, which have a fairly characteristic appearance. And I'm highlighting a couple of areas right here where you see these cytoplasmic bubbles or blisters, as they're sometimes called. See, there's little clear spaces here. And sometimes there may be a little bit of a content to them. Sometimes there may not be. So if you recognize these blister type cells or these vacuolated cells, and you're in the liver, then you might be wondering about the diagnosis of epithelioid hemangioendothelioma. The liver is one of the common sites where this tumor occurs. Bone, lung are also sites where this can occur, as well as other soft tissue sites. And it can have a variety of morphologies. We had a case that was resected recently from the back, which had a very spindly type of appearance, very homogeneous eosinophilic epithelioid pattern, whereas this is much more of a stromal pattern with these variably spaced cells, prominent cytoplasmic vacuoles. And, you know, it doesn't look particularly vascular. There are a few vessels here. And so recognizing this as a possible vascular tumor is just a little bit challenging. You have to sort of stretch your imagination. But oftentimes when you see these intracytoplasmic lumina type of changes, like here, maybe that's got some red cells in it, that can be a clue to consider vascular lesions. And I think once you start thinking about on that line of thinking, you're going to probably end up with this diagnosis of epithelioid hemangioendothelioma. So here's another case, again, another slide, similar sort of displacing pattern. And as you see, it sort of go over here to where it's just beginning to supplant and replace the parenchyma. And you'll see here is maybe a little bit more endothelial type tumor appearance. Whereas in those other areas, we're seeing more of the maturing fibrotic pattern. Here you're seeing more of these epithelioid cells and the vacuoles that we've mentioned before. So if you can get to an area of the periphery, that can help you to identify the lesion. And here's the interface between the lesion with these pale epithelioid cells and the hepatocytes that it's sort of taking over. So here in these more cellular areas, there's a nice sort of atypical giant cell there from this lesion. And another slide example, I think here you may actually be looking at, well, I'm not quite sure if this is, doesn't look like it's biopsy. I thought maybe might have had a biopsy tract or something here. But here we can see some of the intervening tissue and the hepatocytes. As we then come into this tissue, again, you can see how it's squeezing down the hepatocytes, and that's how you end up with that very hyalinized appearance, is because it lays down this matrix and essentially squeezes out the hepatocytes so that they are left without nutrients or connectivity and so forth, and they essentially atrophy away. And that's why you have this lobular pattern, is because that's the way that the growth occurs. So it's quite a distinctive pattern in the liver. This is a helpful feature to recognize as you evaluate these things. Now you might think about amyloid. Amyloid might have a sort of hyalinized matrix, but it would not have the atypical cells, the blister pattern, and lobular pattern of growth that we're seeing here, as well as the luminal features. Okay, one last case. This is actually a case from Hanoi many years back. And this is, again, from a pediatric patient. And here again, we have sort of normal liver here on the edge, liver capsule. And then just beneath the capsule, we have this very altered pattern with lots of small vessels. So we've just looked at epithelioid hemangioendothelioma. This is a hemangioblastomatous type pattern in a pediatric patient. Let's make sure. Yeah, so this is an infantile hemangioendothelioma. I'm sorry, I used the wrong term there. These lesions can occasionally be asymptomatic, and many of them will resolve. On occasion, however, there's so much blood flow through these that you actually end up with the potential for cardiac failure due to the shunting. And here's some residual liver tissue, but then you get all of these vessels here. And so this patient was not doing well, had multiple nodules in the liver. And my colleague there in Hanoi had the brilliant idea to treat this patient with curcumin. And amazingly, the patient completely resolved these lesions and recovered. Now, some patients will spontaneously resolve. And so, we couldn't make the case completely that this was the drug treatment that had done the work. But it was certainly a much more benign treatment than putting the patient on propranolol or doing major surgery or some other feature. And I have it on good report that the patient is still doing well and recently graduated from college and is going on to a great career. So that kind of wraps up our tour of the hepatic tumors that I had prepared. As I've indicated, I will send you the link for the video as well as the link for the slides so that you can study these on your own. But if there are questions at this point, I'd be very happy to answer any of your questions. Let's see, I see there's some in the chat. So let's go to the chat first. Prognosis of hepatoblastoma. So that's a good question. I think there's a staging system, a unique staging system for hepatoblastoma, and it really depends upon the stage. I think it has an acronym like plexus or something of that sort. And the low stage tumors generally do quite well. If it's an advanced stage, they do not do quite as well. Question, have you seen the combined hepatocellular carcinoma and cholangiocarcinoma metastasizing? Is that correct? Metastasizing to other sites? Yeah, so I have never had a combined HCC and adenocarcinoma. I'm taking these slides from a teaching set. And so I have never seen a metastasis, but I've also never seen the primary combined tumor. They're relatively uncommon. And then another good question, Dr. Lin says, what about the difference between small cell carcinoma of the lung metastasizing to the liver versus a primary tumor in the liver when both of them are positive with TTF1? So that's a good question. One of the features that I look for with small cell carcinoma metastasizing to the liver is a very prominent sinusoidal pattern. In other words, it will oftentimes infiltrate in the hepatic sinuses, the sinusoids. And so that feature can be very helpful. A primary small cell carcinoma of the liver is quite unusual. And so it would not be likely, but certainly many neuroendocrine tumors can be TTF1 positive. So not just the ones from the lung in that situation. But most tumors that metastasize to the liver that are TTF1 positive will be metastatic. Most tumors in the liver that are TTF1 positive will be metastatic, either small cell from the lung, neuroendocrine tumor from the pancreas, or other sites. Very good questions, very good questions.
Thank you.
Well, other questions?
That's all.
We've used our hour already. I appreciate the chance to be with you, and I hope this is helpful. We haven't decided what we're going to do next time. So if you have suggestions for a topic you'd like me to cover, please feel free to send that to me, and we'll see what we can do. And so barring that, I'll let you get on with your day. Have a good Friday, and it's always good to be with you.
Thank you very much.